We have time for maybe 2 quick questions. Any questions from the audience? Mary Jane?
So, Alice, I have a question. So we just heard from Kevin Fenton, declining budgets, huge recession. Actually, I would think in Los Angeles we see community-based agencies whose budgets are getting cut. But what we're really advocating increasingly is today, both with Fenton and both Steve and Alice, much more comprehensive wraparound services for the highest risk populations. So there's a huge incompatibility with what we're advocating for and what's going to be funded. And what's happening in Washington, D.C., what's it costing for some of this wraparound? Is that feasibly going to be replicated anywhere else? And Steve, if we were going to take a take-home message, what should we be investing in that, in particular, policymakers are going to go with that's going to be cost-effective?
Well, I guess the first question was directed towards me. I think, I mean, you make an excellent point. I think these are all things that we probably maybe even would have done a long time ago if we had thought about it, but then also if we really had the money to do it. And I think DC is definitely suffering a budget crunch. And actually, I just recently heard that they are low on test kits because of the budget. Well, they're actually waiting for the new budget to come out, but they may not be able to provide free test kits anymore. That's something that they've been able to sustain for the past several years, but I don't think they can do that in perpetuity. Now, I think one thing that, and I wasn't able to mention it because of time constraints, but one thing I wanted to mention was that there are these great and innovative creative programs that the DC Department of Health is operating, but they're not necessarily evidence-based, and there hasn't been any sort of evaluation of these programs, formal evaluation of these programs, and I think it would be really important to implement sort of a cost-effectiveness piece to see how much, like how effective are they, and whether or not they're worth doing in terms of, getting people into care and reducing the transmission of HIV. So that is one thing I think that is lacking, but probably is worth the investment in terms of directing, limited resource dollars.
So thanks for your question. I actually think about this a lot, which is, how can I stay relevant in my work in an era of shrinking budgets? One of the things that's refreshing about the strategy to HIV prevention right now is that it's a data-driven approach. And the idea that you can go out and throw money at all kinds of problems without some sort of evidence of efficacy is gone. And so what I think about in terms of hearing the statistics saying that incidence is the same or increasing in MSM groups and falling in other places, but the same number of new cases are identified every year means that we need to be smarter about working where the virus is. So not only being smarter about working where the virus is, but pulling from different types of treatments and interventions so that we come up with something that's different or more intensive at different levels than others. So for instance, just to make the point, if behavioral, I think we've kind of hit the ceiling for behavioral prevention in its ability to reduce infections. At least that's my read of the data. So providing more behavioral interventions, even if you have different kinds, may not have the intended extra efficacy that you would expect. The excitement right now about the combination prevention approaches is that we have all of these new arrows in the quill, in the quiver back here that are available to us that weren't there a while back, to come up with innovative strategies to bring more potent interventions to prevent transmissions, both within the positive population that's out there, but also in the negative. So I'm not a policy guy, but if I were a policy guy, I'd be pretty happy, because I think that having those sorts of tools right now to really target at the risk communities is really exciting.
Next question, please.
Thank you for your presentation. My name is Camille Abrahams-Amagwali with the Harm Reduction Coalition. I have a question for Dr. Kuo. You talked about models of integrated care, and you specifically mentioned the Valcow study where she talked about the integration of substance abuse treatment with HIV care and also with HIV testing. And I think that that's definitely a model that should be promoted, but also thinking about the fact that there are many drug users who, if they want to go to drug treatment, may not be able to get into drug treatment because there are a great deal of waiting lists, and we talk about funding in that area. And there are also drug users who, quite frankly, don't want to go to drug treatment, but can be accessed, can access care in different ways, for example, with syringe service programs. So I'd like to, I guess, hear more about integrating models of care, specifically with
services to meet the needs of their clients. So they now offer mental health services. They have a psychiatrist on staff, maybe not full-time but part-time, and a couple of social workers who can assist with patient load. They have a series of support groups for substance users, and they also have, I think they either have or had a physician on board who was prescribing buprenorphine. I think that person may have left. But still, they were able to expand their services in order to go to where the epidemic was turning. And I think they actually, and they're the ones who offer dental services, which is, completely overlooked by, everyone in the HIV field, unless you're doing oral health care. So, which I found, really refreshing. So I think, it may not be for every drug user, but I think it's important to have options out there for people who need these services or want these services to be able to access them, to have places to go to access them. And I think an important thing is, what I was saying earlier about the provider who said that she wanted additional training. I don't think it's necessarily that we should have one provider provide everything. I think it would just be important for to ensure that providers are prepared to deal with and identify individuals who may need to access these other services. And the closer, I think, even geographically, the closer they are, the better. I don't have any evidence to support that, but I think that it would be important to, maybe even do some studies around that.
And one final quick question.
Thanks, Bob Rohr. Assuming all of these new interventions we have work fairly well, and assuming we can have the funding and implement them properly, we're still not going to be able to do anything about that one portion of new infections, or very little about them, that are associated with acute infection. And that small window, as some modeling suggests, is up to half of new infections now. And as we roll out these other interventions that we were studying and reduce that sort of long tail during which infections occur, what can we do to try and clamp down on this very small window when viral load isn't in the thousands or tens of thousands, it's in the hundreds of thousands or millions? How can we get this core group, which is responsible for a disproportionate percentage of new transmissions?
You want to do it? Well, no, I think that's it's a really important problem. I think there are definitely new technologies out there that can maybe assist with this. So, for example, some of the diagnostics are getting better where they can detect acute infections or shorten that period of time where they can detect acute infections. And that's why I think it's important to to continue to to urge frequent testing for those who may be at higher risk, or for for individuals who may not be necessarily engaging in high-risk behaviors frequently, but may be part of a high-risk group. For example, Black MSM, who we know, may not have unprotected sex as often as other MSM, but still, we see it in the incidence numbers that they're at higher risk for whatever reason. I think it's also important to not let go of the other behavioral interventions that we've talked about, and I think treatment is prevention. With treatment as prevention, I don't think you should throw the baby out with the bathwater. I think we still need to pay attention to, encouraging condom use, which can then, I think, avert acute infections, protect against acute infections, and other behavioral interventions like that.
I also think, I think that's a great response, but I also think that we're at a crossroads. Those of us in this room are old, primarily. There's a few young ones in here, but generally the field is matured, and many of the new infections you're talking about are among young and under-resourced youth. And some part of their lives is foreign to us. In fact, large parts of their lives are foreign to us, and I think there's a call for some developmental work to find out what some of these forces might be. Some of these young men at risk were born after the identification that HIV was the virus that caused AIDS. They grew up in an era of a lot of sexual transmission disease just on the net. They know how to use the net. There's like social media approaches and other sorts of ways that I don't understand how to do, but that we need to have a new sort of fleet of researchers that are out there pulling this together, because there is a lot of stuff we don't know that's grown up around us while we've been working, and I think it's incumbent on the young ones to be able to go out and find that out.
Well, thank you both very much.